Thank you and good morning to your new viewers.
Dokotela, ungasichazela ngokuthi ubani uDr Lwazi Mkhize?
Dr. Mkhize uvela ekhaya kusemzimkhulu KZN, kodwa ngihlala eNelspruit manje ngisebenzela khona. Ufunde UNITRA, junior degree MBCHB. Ngemva kwalokho ngabe sengifunda eMedunsa for neurosurgery. And ngiqede in 2013. So ever since then I've been in Nelspruit till namanje.
So uma ukuhlanganisa konke MBCHB nokuba Neurosurgeon Specialist kukuthatha isikhathi esingakanani dokotela?
Yo, it's been a while. Thatha isikhathi eside. MBCHB is a 6-year degree, and then internship, community service. Then I spent time going general surgery for 4 years, and then I went to go and specialize again. It took it's 6-7 year degree. So once you get the corner, it takes long because operator, it's not much ukuthi na ufuneka ufunde incwadi kakhulu, into eyiningi ufuneka ube se-theatre kakhulu khona. And nakhona futhi masuqedile awuveli nje uphuma uhambe. Funeka nje uhlale so that ukwazi ukufunda uku-operator kahle without the books ecaleni nje. So you spend about 2 or 3 years just operating. And then ngemva kwalokho you are ready ukuthi uphume manje ukuthi uyozimela wena ngokwakho.
Usebenze ku-private.
Yeah.
Phela masikhuluma ngama-neurosurgeon sikhuluma ngalabo dokotela abayikhipha ingqondo bayibeke eceleni bayi-operate. Kanti i-maxillofacial Dokotela Mogajane, khona li-dentist, khona li-orthodontist, khona li-maxillofacial, kanti li-differa byang?
Okay, starting with maxillofacial, I think firstly we must acknowledge that maxillofacial and oral surgery is a very rare specialty. Hence, you see most of patients don't even know it. So, in definition, maxillofacial is a dental specialty that combines surgical training and dental expertise to treat a variety of diseases, injuries, tumors, cancer, deformity, and cleft to make sure that you correct those situations. And then I've got a nice model to demonstrate about it. When you look at the human face, it might look small, but I mean in terms of size and structure, but in function it's very big and very important, because you've got a lot of vital structures that are contained within the face. You look at the 4 sinuses. I mean the 4 senses out of 5, like your vision from your eye, your smelling from your nose, hearing from the ears, your breathing, your swallowing, and all that. So this structures that are contained in here. Okay, the other thing that I forgot to mention, that face also is where it gives one identity and facial expression. So you can imagine if you get injured, you might not look as beautiful as you were before. So that is why part of the objective and goal of managing that condition will be to make sure that we restore those function and your looks back. So in a nutshell, it's what maxillofacial it's all about. And then it's a specialty in dentistry, like you mentioned, orthodontist, and there's a few of specialty within dentist. I know most of the people, they think dentist by itself is a specialty. It is not. You get about 5, 6, 7 more of specialty in dentistry. And then to do it, you go for undergrad training for 5 years for degree of dentistry. From there, you go work for a few years, and then you go back to postgrad. That's where you do 4 years, further 4 years, and then you qualify as a specialist maxillofacial and oral surgeon.
So Leona it's about 10 years, 12 years so.
Exactly, yeah.
Wow. No, but baba laba. Beno ngaka ke nyako just o re tseye Dr. Mogajane o tswala kae gae matric o irile o hiretse kae ke nyaka batho ba bone gore go ba maxillofacial a o nyake gore o be o golle maybe ko di sentine, you know. It takes a black child from there go rural. Dr. Mogajane o tswa kae?
Okay, I'm from a small rural village in the area of Denelton, the village called Maxillofacial. Yeah, that's where I was born and bred up, did my primary school, my secondary. From there, I went to Medunza to do a degree in dentistry for 5 years. Went to Nelspruit in Tampa Hospital, worked for about 5 years, and then went back to Vet Circuit to specialize in this specialty. Then I'm back in Nelspruit working in private practice and Kiat Private Hospital.
Hona beno o bereka Nelspruit le wena?
Yeah,
Mpumalanga Nelspruit awumncinyane nawe. Nawo ama specialties ethu lapho sivela khona nami lapho engivela khona. Kanti ngiyaziqhenya ngeSMU le ekudala besibiza ukuthi Medunsa. Lapho university lapho sonke sivela khona. Sithi halala Medunsa. Dr. Mkhize, ake sichubeke la. Sithi ama head injuries maswabiza ukulimala kwengqondo. Dr. Mogajane usesikhombile ukuthi bona abasebenza nina njengama head neurosurgeon mayakuthiwa ama head injuries nisuke nibuka kuphi kahle hle?
Okay, ukulimala kwekhanda kwenzeka kabili.
Okay.
Ulimala at the accident scene. La ushayeka khona ngekhanda. Now ukushayeka khona kwekhanda ungenzeka into eyiningi nakhona futhi in that ungalimala the actual skull where the actual skull bone can get damaged. Now kwezinye futhi that is called where ingqondo izobonakala konke nje kuvuleke. That is called an open injury. Now kuba khona ke amanye ama-injuries la uthola ukuthi khona konke ku-right kodwa ulimele ngaphakathi. Now those injuries are called closed injuries because mawubuka la ngaphandle akukho nix and kodwa ngaphakathi umuntu ulimele. Now if ungacabanga or look at ingqondo as jelly. Now if ujeli uhlele a plate and you shake it, the jelly shakes. Now into eyenzekayo ngaphakathi ekhanda lento. But inkinga is that the jelly will hold its form, but la ngaphakathi it really does not hold its form kahle because of the impacts, the large impacts ezenzekayo. The same thing that if you uthatha ujeli uwe uzo. But now lonto leyo mayenzeka within the skull. Now izinto ezenzekayo ke manje that is the initial injury oyitholayo. Now kuba khona ke kuthiwa primary injury ke yonke leyo. Then you get what we call a secondary injury ke manje. Now the secondary injury eyenzekayo is lapho ke khona ngithi mase ulimele, it's not only ikhanda limalayo. Umzimba wonke nawo futhi uzolimala and then uthola ukuthi nawo usakwazi ukuphefumula kahle. Now mawungakwazi ukuphefumula kahle i-oxygen njengoba ayizukwazi ukuthi ifike ekhanda kahle. Now that is what we call secondary damage. Okay. Now thina la singena khona is that we try and prevent secondary damage from happening or to limit secondary damage. The initial one, there's nothing we can do about it.
Sure.
It's the secondary damage there as a limiter because if you don't get enough oxygen, if you don't get enough blood, if uphela ngaphakathi kuba inkinga leyo. So ke zonke lezo zinto lezo zo-3 kakhulu ilezi esizama ukuthi na sizilungise and sizama ukuthi na siprevente further damage from happening.
Manje Dr. njengoba usho ukuthi kunokushayiseka, usually lokushayiseka kukhona ukuthi umntwana awe embhedeni awe ngekhanda, kube khona ukuthi mhlambe car accident. Ngabe yiziphi ezinye inkinga mhlambe abantu abahlangabezana nazo ezigcina zikhoza lama head injuries?
Well, njengoba usho nje ukuthi it's car accidents, ukuwa kwengane, mawulwa nomuntu, manqindi, all that energy that is transferred to the face is also transferred to the ikhanda futhi. So okay, anything that affects ikhanda or ithinta ikhanda, that will cause damage to the brain. Now, ukulimala kwekhanda, it varies. It might be minor to major,
Okay.
and even the major leading up to death. So okay, it's a scale. Ukuthi na uma ulimala kangakanani and how severe it is. So in severe injuries, abantu abazitholayo uthola ukuthi na umuntu ushona at the scene, and there's really not much we can do about it at that point.
Okay. Ngifuna ukwazi la kuke kwenzeka ukuthi uthola ukuthi umaki umuntu wesimama uyateta lapha labor room, then bese kuba khona ukuthi mhlambe bayamncedisa abodokotela nabo nesi badonse, and then sometimes basebenzisa insimbi ukuthi bakipa lo mntwana. Lawo ma incident a common kangakanani ukuthi angakhosa ama head injuries?
Okay, now that's the beauty part of uNkulunkulu wethu. Yabona, angazi ukuthi nabazoyibona kahle nalento, ukuthi there are these lines ezilana.
Okay.
These lines here at the back. Now, most of the minute you get to about 18 to 21, this is fully formed. Now, most ingane, you get this bone here. Nala, nalela. Nala part of foot ivulegile foot. And konke nala mathambo lana avulegile. Yiko nje ingane encane moyithinda la uthi awunofokotho. And mothinda nalana futhi uthola ukuthi nayo there's kuneno. But especially the newborns, mothinda nje nala uyezwa nje ukuthi na khona space. Khona space. Now muphuma through the birth canal, because of these spaces, the head will collapse a bit, so that ukwazi ukuphuma. Then once uphumile, everything will go back to normal again. Now, even if you're doing assisted deliveries, forceps deliveries, zonke lezo zinto, they squash the head, but the things that there is leeway.
Okay.
Ukuthi now collapse, uphume, then over a period of a day or so, then everything goes back to normal, and then but even then, the shape of the head is determined by what we call them sutures. But as they close, then they give you the shape of the head. But low shape of the head is also determined by ukuthi na ingqondo yakho ngaphakathi ikhula kangakanani.
Uyichaze kabanzi uDr Mkhize le ndaba ngoba ngiyazi kukhona laba basekhaya abahlala bakhala ukuthi ngathi mangiphusha umntwana wadonswa walimala inhloko. Uyichazile dokotela namhlanje sine clarity ukuthi kwenzakalani kahle hle. Dr Mogajane, beno more maxillofacial fractures. Sona di cause again. Part of it is sona the accident kapa kuna le dilo tse dingwe tse causang the maxillofacial injuries.
Okay, mainly it's intrapersonal violence, assault, especially in South Africa. I mean that does suggest that our community within the country is very rough. Secondly, on the list, it's motor vehicle accidents. You get sports-related injuries, industrial injuries, even animals. You can also get a fracture because of a pathology. Maybe there's a cyst in your jaw, then you just get a spontaneous fracture. So these are the, the possible causes of these fractures.
Okay.
Yeah.
So, since the fractures, una these differentiate bien. Una these fractures.
Oh yes, okay. What we do, we divide or we classify the face in three third. I mean, yeah, in three third. The first third is from the biting line to the lower part of the lower jaw, the mandible. And then the middle third is from the biting line just below actually above, below the eye rather, below the eye. And then the upper third is from the up this side of the eye right to the vertex of the head. And then from there we can further classify the lower jaw, the mandible. You can have a fracture of the, let's see if they can see, this part of the lower jaw, we call it a condyle. You can have a fracture of it. And then just to, say something about it, it's very, dangerous if you can have a fracture of the head of this condyle, because it forms the part of what we call a TMJ, temporomandibular joint. And we know a joint is a closed space. So when you've got a fracture of the, this part of the bone, you'll get a bleeding inside, and then that bleeding, because it's enclosed, it might organize itself and calcify, meaning form bone, and then that bone will breach. As you can see, it's let's see if they can see. You can see it's a joint, it moves. So if there's a bone breach, you get what we call ankylosis, meaning the jaw can't open now. Okay. You can't even move a centimeter. Okay, I just wanted to say something about that. The other thing that you can get, especially if you sometimes you get patient having an impact here on the chin, okay. So all the forces can be transmitted here. Sometimes you can get this part of the joint, part of the bone, perforating into the brain in middle cranial fossa, which is a serious life-threatening, situation. From there, you just classify which part of the, lower jaw. You can have an angle, we call it the body, a chin, we call it the symphysis. And then from there, we go to the middle third. That's where you talk of the four fractures. Normally, it's a fracture that will just come this area to come here, and then is a L4-1, L4-2 will come here, and then come this side. L4-3 will involve this part. Normally, you get fractured where where the bone is weak. The weakest part of the bone. That's where it will likely fracture. Yeah. Okay. And then you can also have a fracture of the orbital volume inside. The zygoma, the frontal sinus, the nose. The dead bone, and then they get treated differently.
You treat them different.
Yeah.
So, thing a common maxillofacial bone
Okay, a very good question. It's a lower jaw, what you call a mandible.
Okay.
Why? The reason for that is because it's mobile.
Yeah.
It's mobile. And then it's also like protruded, it's in front.
Yes.
And then also, normally, like I said, assault is the main cause of this fracture. You find that when you get assaulted, somebody who's assaulting you, normally they target the lower jaw. Sure. They won't, throw your fist, their fist to your forehead. Yeah, they target, the lower jaw. And then it fractures more often.
So how can you react or maybe mutu unali accident thing or hona ba mushapile, but bo ngaka mo ba focus on more braining kanti unali mandibular fracture, and then it was misdiagnosed. It had complications, I think.
Yeah, if it doesn't get treated, firstly you might get an infection, because normally when you've got a fracture, you'll get fragments of bones, pieces of bones within the fracture line. And then if those fragments were not removed, debrided, they'll act as a foreign debris, which will induce infection. Also, you find that there's a change in, occlusion, the way you bite. Patient will tell you, see, when I bite on my left, the right side is open, I can't chew. Also, you can have anesthesia or paresthesia. My lip is numb, I can't feel it, because there were nerves that were inside the bone fragment that are pressed, hence they can't function. And the other thing you can find a facial asymmetry. Find that the jaw is shifted, comes in lily one. And then generally, like if you talk of generally, even the eye, sometimes you get a fracture within the eye orbit because the socket it's surrounded by bone. So if you get a fracture, especially on the floor of the orbit, you find that the eye suck inside, you know, because it's a very thin bone there. It can easily suck inside. And then the result will see, the result will be patient will see, I've got a double vision because of a change of position. The eye was not, repositioned to where it belongs. Yeah, something like that.
Okay. Ke a kry-a bjanong picture ya di-maxillofacial go raya gore ke dingaka tsa marapo a sefatlhego pila di-orthopedics tsa mo fela. So because di-orthopedics di berekisa di-plaster, lena le berekisa le chin bone yaka e fatlhegile mo le berekisa eng lena?
Okay, speaking of plaster, we've got a method, they call it a close reduction.
Okay.
Fixing the bone and open reduction. So close reduction, orthopedic, they'll put what patients call cement,
Yes.
you know, right now because we can't put a cement when you're broken on your jaw. So what do we do? That's why you see patients with wires, with their mouth shut. Yeah, the reason is that is to make sure that we immobilize the fracture. We don't want it to move because the bone will only heal when it's fixed, when it's still, when there's no movement between the fragments. So we put the wires around the teeth, and then the patient will be like shut for about 6 weeks. Normally, a bone will need 6 weeks to heal, and then otherwise we put like when you do open reduction, that's where you will cut the gums and open and expose the bone, and then you put this. I think this shows nicely. Yeah, the patient would have had a fracture here. This one will also show nicely. Can you see there's a fracture here? So what we do, we open the gums to expose the and then you treat it directly. You put this plate and screw that also, even the neuros, they use this plate and screw. And then I think what I'm having in my hand is just to show you that if you use one plate here, because of the muscle pull on the jaw, you find that this thing will keep on moving like this, and then when it does this, you won't find a bony union. There will be a fibrous union. Then when your patient tries to chew it, find that the jaw just tangled and it's uncomfortable. So that's why you get to make sure that it's fixed, it's stable, and then the bone heals without a problem. I think still on the, like you ask of possible complications, thinking of it, you can have sometimes you get a non-union of bone or malunion. Malunion will be, the bone will be healed, but it will be shifted. Obviously, when the patient bites, the teeth won't come together nicely. And like we're saying, especially the management of these bones, the ultimate goal is to give the patient back the bite, the occlusion. Because I'm sure if sometimes you can bite on a smaller yana, the suikanyana or something hard, the way it's uncomfortable, you feel that the teeth on the other side doesn't come together, but here they come together. Or sometimes when you have a dental, feelings, if that patch is a little bit higher, when you bite, you can feel good, say, hey man, I can't chew this side. So that's why it's very critical to give patient back. We call it occlusion, like biting nicely so that you can enjoy your food and chew. Yeah.
Siyafunda namhlanje, siyafunda kakhulu.
Yeah, maybe still on that. Like we're not only treating the facial fractures, also patient with tumors. Some patients they come with tumors and cancer. So what you do, cancer surgically you remove it. After removing it, now you must reconstruct. Because can you imagine if the jaw is like this and then you cut here, now there's a gap, there's no teeth, it's even your shape will change. So we do what they call a bone graft. We take a bone somewhere from your body, and then we graft it here. We can mill it and make it a powder-like, or take a a normal bone and bend it according to the arc, and then we put this plate to secure it. We can even later put dental implants here, false teeth, to give you back your occlusion. The other thing still on that, like this TMJ joint is very important. Sometimes you've got a tumor involving this part of the joint. So if you cut it like in this side, if you cut it, obviously the occlusion will shift. So to restore it, we do we replace the joint, artificial joint, as you can see here, so that the patient is we give occlusion back. It's a lot.
Yeah. Dr. Mkhize, kukhona lento abathi yi-baby shake syndrome, and abantu abaningi bayayithanda ukuthi umuntu uphakamise ingane ayidlalise ayise phezulu, and usushilo ukuthi la ingcondo ifana nejeli. Akusifundise kabanzi ngalokho.
Okay. Let's start with the brain itself. If Momo Ibona, it weighs about 3-4 kgs.
Okay.
The actual brain itself. But now, mailanga phakathi, there's a fluid, a man's around it, which is called the cerebrospinal fluid. Now, no fluid layer, basically what it does is that it provides a cushion, and it also cleans the brain, and it also provides nutrients for the brain as well. Now, when the brain is seated in there, the weight yayo decreases to about 500 grams. Okay. Now, that CSF around it provides cushion so that during any normal movement, so that your brain does not hit the skull in front, it does not hit the skull as you move. It provides that cushion under normal circumstances. Now, the brain basically is in a DJ. Okay. Now, most of you can even try it at home. Wednesday, take jelly, put it in a dish, and then shake it. And then you're gonna start seeing cracks forming as you're shaking it on the jelly. Now, as you're shaking it, it's the same thing as we shake our ingane. And then you imagine all the blood vessels that are there, because they can't move too much because there's not a lot of give. Then when blood vessels do this, then they shear. Then we told hi, akalimalanga akwenzekanga lutho kodwa masibone ukuthi ngaphakathi kwenza CT scan sibheka ngaphakathi there's a bleed. Now ubuza ukuthi nake now yenzeke kanjani nani hayi akabanga kanjani uyawamshayika na.
Okay.
Then ubone parent bheke eceleni hayi umalume wakhe yabo. So okay, ingane, you don't do this.
Don't
do that, you don't do that. No matter how angry you are and ungafuna ukumshaya and umbambe umthi, no.
Wow. Manje njengoba usichazile ukuthi kuba nama contusion, kuba nama bleeding, yiziphi ezinye inkinga ezivelayo uma umuntu alimala la emqondweni?
Okay. Now the thing is that those initial injuries, the brain is divided into two. You get around the grey matter.
Yes.
And then now a grey matter basically it's what we call the nuclei that are there. And then you get the white matter, which are actually the axons, because a nerve cell has got a nucleus and then it's got the axon. Now the axon basically where the message from the nucleus is transmitted through to wherever the nerve is going. So okay, you've got all these around, which is called the grey matter. And then in the axons that are combined, which flow to the rest of the body, those are called, those are the axons, which is called the white matter. Now, the two have got different weights. Okay? So again, now the gray matter is heavier than the white matter. Now, Jemba, who heavier than the white matter, if you shake, if you do anything, and there's a sudden stop, they're both, this is at different paces. The one that is heavier is going to take longer to stop. The one that is light is lighter, takes shorter to stop. So then now what do you get? You get nucleus, that's the axon. Heavy, light. We stop. Stops quickly, takes longer to stop. Now when that happens, they snap.
Yilapho kusokuba khona mhlambe lama diffuse axonal injuries.
That's where again kuthiwa ke manje umuntu une diffuse axonal injury. Now the things that a diffuse axonal injury is basically histological diagnosis where you take and then you look underneath the microscope. But we can't do that.
Yeah.
Now, how do you infer what you would find with microscope to, because then you look at the CT scan to try and see which more bigger a scan, which diffuse axonal injury is it? Now, a CT scan will tell you what because in normal cases, if you do a CT scan, it comes out it's normal, but is in a coma. Then you know that was a diffuse axonal injury.
Oh, so ni rely kakhulu kuma CT scan ukumake ama ho we are rely uri mo CT scan u diagnose the maxillofacial fractures.
Yeah, especially certain fractures. Normally, the lower jaw, the mandible, plain normal X-ray will do. But when you go to the eye, the zygoma, the cheekbone, you CT scan, it's a standard.
So, what to have a more accident? Everyone who comes in and there's a maxillo head injuries, she needs to go to for CT scan. That person.
It's standard.
Okay. Manje dokotela la sesifuna ukwazi before sigoqa ukuthi msenibonile ku CT scan nangu umuntu kune bleeding lapha niba treata kanjani?
Okay, it depends. If like I said, there are hematoma. Now, hematomas you get two types. You get the epidural, you get subdural, and then you get intracerebral. Now, all of those you are classified because of the layers of the brain that come around. Now, you've got the actual brain itself is covered by a layer which is called the pile matter. Then above that, you've got the arachnoid. Then above that, you've got the dura. Now, all those layers, they are there to protect the brain food. Like I always say to people, the body is there to serve the brain. And the bandamaning by Now, the things that everything is there to protect the brain and everything. Now, any bleed that comes from above the dura is called an epidural hematoma. Now, those hematomas are caused by fractures of the skull because the mitambo and arteries that take blood to the brain, and they go right underneath the skull. So now if the skull is cracked, then the bleeding will happen. Now those are emergencies and you need to take the patient to theatre immediately to evacuate that bleed because once you remove the bleeding, the person lives.
Kanti imaphi ama complications ke ukuthi mhlawumbe umuntu angathola usizo masinyane ama neurosurgeon uyazi nawe ngathi ni 2 ni 3 lapha eMpumalanga nibancanyana.
An epidural will continue to bleed. So it will get bigger and bigger and bigger. Now you've got a finite space langa phakathi ekhanda. Now you get what we call raised intracranial pressure. The pressure ela ekhanda ngaphakathi, it goes up. Once it starts to go up, then the structures inside the actual brain, it will start to uzofuna ukuthola spaces sokuphuma. Now it's only got 2 spaces or 1 space engaphuma kuyo, which is here. Now once the brain starts to come out of here, here is where the spinal cord comes out, and you have the place now where your breathing apparatus, where your heart rate, everything, yonke into oyenzayo that you are not aware of or you don't control when yourself, that area gets squashed. Once it's squashed, sekuphele.
Manje ngizwe Dr. Mogajane athi sometimes kuyenzeka ukuthi uthole ukuthi ithambo leli lihlabe ibrain. Nenza njani mase nilapho nise theater niyama nibize bona ukuthi buyani ezosusa ithambo leni kwenzakalani?
Okay, where we work kakhulu with maxillofacial doctors is injuries that mainly happen round about here in the front. Now, what usually happens kakhulu is that okay, let me open this with your permission.
Yeah.
Okay. Now, the thing is that this is what we call the base of the brain. The brain compartment now, it's divided into 2. You've got the supratentorial, you've got the infratentorial. Now, the tentorial is in this area here. It covers this area. So now whatever is above it is what we call supratentorial, and whatever is below it is infratentorial. Now, and there's a whole lana. I don't want to get too technical, which is where the actual axons and everything, they move through. Now, when the injury is here, which we call the anterior cranial fossa, now we are wondering now, which in the roof of the eye is the base of the brain.
Yeah.
Now, anything that happens in this area here, we have to manage together.
Okay.
Because when there's a leak or muscles go inside or anything that happens, Lana, then we have to open and then fix this area here and then close again.
Okay.
So this is where you usually find in theater, I will come, I will open, and now remove this part, they work, then I close.
Oh, that's nice. Ukuthi ningalokhu nibisela i-patient back to theater. Okay.
Yeah, it has to be coordinated with when you go to theater. So to where I open, they work, then after that I close.
Oh, that's ukubaluleka kokusebenzisana kwama-colleagues, kwama-specialists, nabodokotela kanye nabanye futhi odokotela kubaluleke kakhulu uma siza ku-management of the patient. Dr. Mogajane, masibheka lana njengoba sesisho ukuthi wena udokotela wamathambo wasebusweni. Bamathambo kukhona i-dislocation common kakhulu, shoulder dislocation. Nakini kukhona i-dislocation ye-TMJ. Yeah, akusichazele ngayo ngoba ngeke ngibona abantu afika umuntu athi bekathi uyazamula sekutshekile lapha emlongeni. Ngicela usichazele nje ngale TMJ dislocation.
Yeah, like I explained earlier that there is a joint here that connects the lower jaw and the middle face. So sometimes when you, the possible causes when you yawn too much, you open your mouth too much, it can happen just talking, singing or eating. But normally, not everybody will dislocate. Normally it's because there are structures that hold the two bones together. Your ligaments, your muscles, sometimes even the bone itself. Those are the factors that can lead that. If the cartilage they use lax, meaning they stretch easily, instead of because those structures, they hold the joint together so that it doesn't just move anyway. So if they're too lax or elastic, it can easily come out of the socket. So when it's dislocated, it will come out of this area here, and then what will happen is gonna do this. And then something like this. If that is out of the socket, and there's going to be something like this, and then Sometimes, it's self-reducing, meaning patient can just easily, take it back when they try to maneuver their jaw. Sometimes it's difficult, they'll need, our attention. And then what we do, we just maneuver. There's a way of maneuvering the lower jaw to, reduce the joint.
More that maneuver because nkile ka bona ngaka engwe e tsentsa matsogo mo la area a goga meno a la boa tlhakana le matsogo go ba spitipiti mo la pela o tlhalose gore tshwantse re reduce bya.
Yeah, because it's very painful, when the joint is dislocated, because those muscles and cartilages are stretched. So it's very painful. So when you try to maneuver, the patient, might easily bite you back, So the simple way, it's I think you hold a jaw like this, because, and then what you do, you pull it down, and then you slide it back into the, the fossa where it belongs. You just need to be careful and be fast when you do that. But that is possible if it's an acute thing. It happened, today or yesterday. Some patients, they come after a month.
Yes.
And then with the muscles there now, they're stiff, they're fibrosed. It's difficult now. Because normally you can do this just on a chair in casualty. But if it's difficult, you need to take patient to theater. Try to paralyze the muscle, make it loose, and then maneuver it. Sometimes, if it's that difficult, you can even open, make a surgery now, pull it back, through that way. Yeah, and then just wanted to add on the positive. There are some medication also that, can cause the ligament to be just loose. And what we find is it mainly happen on a female. Reason for that is not yet established, but we mainly see females coming with dislocation. And then sometimes they are classified into two, acute one, and then that just happen one, then you fix it. But most of the time, if you have it, you have it now and then. And then you have those that comes with a recurrent. You say always. Then in that case, you need to do a surgical intervention.
Okay.
And then when you do surgical intervention, you look at the structures that are involved in joint stability. Like I said, bone itself, cartilage and muscle. So you deal with either of them. You can also just take a blood from the patient, inject within the capsule. So what they do a fibrosis around there so that it's not loosely go anywhere when it's tough and stiff. Sometimes they happen because the muscles are spasm. What you can do, you can put even Botox just to relax those muscles. Sometimes when those muscles are relaxed, if it comes out, it goes back because they are not, stiff. And then you can do surgery to modify the bones that are around so that, it doesn't move out easily, or it moves easily, but it easily, go back also. So yeah, there's a few modalities for doing that.
Okay, ngaka. Since re tswalla meno, re ka prevent bjang di maxillofacial injuries le di fractures?
Okay, in terms of road accident, injuries, very critical safety belt. We always see patients with massive fractures, mesh face. When you ask them, did you have a safety belt? No, I didn't. I was just going to garage to buy bread. You don't do that. Whether you're just going around the corner, safety belt, you don't know what may happen. Truck might come and smash you. So, and I'm telling you, those who have a safety belt, when they come, even if they've got a fracture, it's just going to be a single fracture here that is easily to be managed. Yeah, safety belt is very, very critical. We, struggling to put a message across to our patients. Because remember, when you don't put a safety belt, when you got accident, when the car roll, you will roll like a ball inside the car, head, hit left and right seats and da 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 da. And then in terms of injuries from the sports, those cricket shield thing, those things, they can use that. And then interpersonal violence, I don't know, but patient must just avoid, involving themselves into, violence. You find most of them say, no, nekela mola, nekela mola. Yeah. Exactly. And then, mainly are those. And then the other thing critical that I must mention, avoiding those fractures. Normally you get those teeth that they call wisdom teeth. They are the last tooth on the jaw. Normally, because of lack of space of the arc, they erupt late, and then you find that they stuck within the jaw. And then when they stuck within the jaw, you find that this area of the jaw is weak.
Okay.
Yeah, a mild impact can fracture, especially on the angle of this jaw. It fractures easily. We always advise them that remove them so that there's no a cavity within your angle, because otherwise this area is very weak. That's why when we were asking which part of the mandible, of the jaw, the angle especially, that fractures easily because of there's a tooth inside. The jaw at that area is very weak, is compromised. Yeah, part of avoiding them or preventing them, those things. And then like the others, like animal kicks. I mean, sometimes people get kicked by animal. I don't know how to say avoid. From animals in factory, people must be careful.
Okay.
Find patient, all those things. Yeah.
Awarile bokhethatha ngaka. Dr. Mkhize, ungathanda ukuthi abantu bafundeni namhlanje ngalama head injuries bazipreventele kanjani futhi kuona?
Oh, my head injuries, like you said, mawusemotweni faka i-seatbelt. Whether uhleli ngaphambili, uhleli ngemuva, faka i-seatbelt. Be sensible when you're driving. I know ngezinye izikhathi the accident is not your fault. It's another person's fault. But the thing is that if people are sensible when they're driving, that's the best thing. Don't drink and drive. And people who got motorcycles as well, the helmets, very important. So be cautious and safety, be sensible. That's all I can say. Be sensible. And interpersonal things like even fights, they cause head injuries. Stay away from fights.
Yeah. But that's beautiful. Yeah.
So stay away from fights. Mawubona ukuthi umuntu usephuzile and unochuku, just stay away. Better to walk away and then be called a coward than ukuthi ume ulwe ulimale.
Kanti yiphi i-worst complication kuma head injuries nje le ukuthi is the worst of them all ngaphandle kokufa ngaphandle kwakho ukufa?
It ranges because from death you get to be what they call a vegetative state. La usembedeni, you can't do anything. You dependent on everybody else. You can become quadriplegic. Luckily nowadays, even those who are paraplegic, there is rehabilitation for them. They can use wheelchairs and they can still go back to normal society and be productive as a paraplegic. In milder forms, where you get what we call a post-concussion syndrome, where it lasts on for very long, where you get headaches, and those headaches don't go away, and you always got headaches. You always got headaches. Now the things that doctors become frustrated because they can't treat your headache. Now if you become frustrated because we are with hi, I've got a headache, and people they give you medication and I'm long. Depression comes in, and then people have suicidal thoughts. So it's a range of things that
futhi bayanokufitha after my head injuries.
Yes, Now those happen especially if the brain was lacerated in any way. So let's say if umuntu showering with a hammer or a stone and the bone cracked and it lacerated the brain, seizures. You're definitely gonna get seizures.
Uzvele nawe lapho mbukeli ekhaya sifundile kabanzi namhlanje ngama head injuries kanye nama maxillofacial injuries. Ngibonga ngikuyihambeli zami Dr. Mkhize nawe Dr. Mogajane. Nisale kahle babukeli emakhaya siphinde sibonane futhi same time Saturday 9 o'clock ezempilo zami utakalo. Ningakhohlwa ukusubscribe kuma YouTube wami noma ku Facebook ka Dr. Pro.